Hi everyone, very good evening. Welcome for our third session of our respiratory month. So without further ado, I would like to introduce Dr. Jamalul for today's session as a chairperson. So our topic for today is clinical role of pulmonary function test. So Dr. Jamal is a consultant. He's a consultant pulmonologist at Sedang Hospital. He's a chairman of Malaysian Association of Bronchology and also Interventional Pulmonology. He has a vast experience treating respiratory diseases for more than 20 years. So without further ado, we would like to invite Dr. Jamalul to chair this session. Thank you.
Thank you very much, Dr. Jeevan, for that kind introduction. Assalamualaikum and a very good afternoon to all the attendees. Welcome to this teaching webinar. So we have here a distinguished speaker, Dr. Kumaresh Raj Lakshmanan, who is a consultant pulmonologist at the Hospital Raja Permaisuri Bainon, Ipoh, Perak. Just a brief introduction about Dr. Kumaresh. He's a graduate from University Malaya, and after that he obtained his membership from the Royal College of Physicians, UK, and subsequently he subspecialized in respiratory medicine or pulmonology. And as part of his trainings, he rotated in various places, including Penang Hospital, Institute Perubatan Respiratory, and Sedang Hospital. And he also spent almost a year in Perth, Western Australia, and he had a very good exposure in pulmonary physiology and sleep medicine when he was in Perth. So to me, Dr. Kumaresh is easily the best, person among his peers to speak on the role of respiratory function test in our daily practice. I do hope that there are now 94, almost 100 participants. I hope that this will become an interactive session rather than a didactic one. And we do hope that there'll be many questions from the participants. Don't be shy to ask questions. You can post your question in the Q&A box there. So you don't have to speak at all. Don't worry about your language. We want to hear from you. So, and I'm sure that Dr. Kumaresh can make this talk very interesting and interactive. So without further ado, Dr. Kumaresh, please.
Okay, thanks, Dr. Jamalul, for the kind introduction. And thanks to the Academy of Medicine as well for this invitation. My topic today will be on clinical utility of pulmonary function testing. This is quite an esoteric field, which is not well promoted among our general medical colleagues. It's usually just limited and restricted to the pulmonary fraternity. So the objective of my talk today is actually to introduce this overall concept of PFT and highlight how we as pulmonologists actually use it in our clinical practice, and also to spur interest among our general colleagues. In the interest of time, I must apologize that I can't go into great details on technical performance and interpretation, but I will try my best to cover as widely as possible. So the outline of my talk, generally, I think prior to understanding PFTs, you need to know how the lung works. So I will start off by a brief primer on the lungs. Then subsequently, I'll go into the components of PFT, basically focusing on what we have in our local setting. Then some general rules about pulmonary function testing. And finally, I'll end with some clinical application. So children actually do this in kindergartens these days. They produce models of lungs. Basically, how our lungs are structured is the easiest way to understand is basically it consists of airways, the lung itself like balloons, then our thoracic cage where our muscle and chest wall is, and also diaphragm, which is the most important respiratory muscle. So I will walk through in the subsequent slides how each of these components actually contribute and work. They dovetail to actually let this organ function. So the tracheobronchial tree begins from the larynx. The territory above is usually belongs to ENT. So we start from the trachea and subsequently divide into 23 further generations. Roughly at generation 16, 17, we transition from what is known as the conducting zone into the respiratory zone. Beyond this, gas exchange potentially can happen, and best happens in the alveolar ducts and alveolar sacs. The higher zone, the one above from 0 to 16 is basically functions to conduct air, the atmosphere air into the respiratory zones where gas exchange happens. So obviously the entire tracheobronchial tree is relevant to our breathing process, and the airway properties of interest that can actually result in diseases, respiratory diseases. We are actually interested in resistance, the tubes, the conductance. Conductance is basically the inverse of resistance, and also resistance usually leads to obstructive airway disease. So that is the one property that we're interested in, namely diseases like asthma and COPD, which are obstructive airway diseases. Other properties of the airways that pulmonologists are usually interested are hyperresponsiveness and also reversibility. And third is distribution of ventilation, how the airways actually distribute the air that actually enters into our respiratory system. So each one of these components actually contributes to disease processes. It does not necessarily mean a specific disease. Various diseases can have these various properties affected to varying degrees. But these are the properties that we would like to interrogate, and later when I go into the pulmonary function testing, I'll be referring back to this. So once the air actually goes through the conducting zone and goes into the transitional zones and actually expands the balloon or the lung, the mechanics of the lung is basically determined by the parenchyma, the interstitium, the alveolar surface, and the pulmonary vessels. Whereas the mechanics of the chest wall is the property of the structures external to this lung, referring to the muscles, the chest wall, the skeleton, and also the diaphragm. So, but the interaction between the lung and chest wall is actually they don't interact independently. They actually work very well. So, if this is actually the pressure volume curve, which indirectly implies the compliance of the respiratory system. So, if you look here, the broken lines on your left. This is the compliance of the chest wall, whereas this broken line is the compliance of the lung. It is the summation of this that gives you the solid line, which is the compliance of the respiratory system. So you can look, you can see here there's infinite number of possibilities, infinite numbers of lung volumes that you can infer from this combination. So there are few points that are clinically relevant. The TLC, which is the total lung capacity, the FRC, which is the functional residual capacity, and the residual volume. So I'm going to define these terms in a subsequent slide. So these are the These are the points or the volume points that are relevant in our clinical practice. So the other thing is, other important component is how the pleural pressure actually oscillates between inspiration and exhalation. However, in routine clinical practice, in standard pulmonary function testing, this is not done because to actually interrogate the pleural pressure, you need invasive tools. So it's not routinely done. And to the best of my knowledge, not done in Malaysia. So what I alluded to earlier, the few volume points which are very important to know in our clinical practice. First is total lung capacity. So without actually using highly technical terms, TLC basically means the maximum amount of air your lungs can hold. So after you have emptied your lung, you take in a maximal inhalation. That volume is your total lung capacity. That is as much as air that your lungs can hold. Residual volume is the opposite of that. Basically, you have exhaled as much as you can, and the remaining air in your lung, that is residual volume. Basically, you have emptied your lung to the best of your ability, and whatever is remaining in the lungs, that is known as residual volume. Functional residual capacity, which is your FRC, this is basically the volume of air contained in the lung after a tidal exhalation. That means your tidal breathing, your normal breathing, you inhale and you exhale. At the point that you exhale, that is known as your functional residual capacity. This is during tidal breathing. And your tidal volume is the volume of air that you breathe in and out of the lung during a tidal breathing. That means normal breathing. So in a complete pulmonary function testing, we usually like to look into TLC, RV, and FRC because it contributes most to clinical interpretation and clinical decision making. This is a graphical presentation of the lung volumes and capacities, which I mentioned earlier. There are numerous, about 8 of these parameters, but I'd just like to highlight those that I mentioned earlier. So total lung capacity, basically all that your lung can contain. That means a maximal inhalation after you have emptied your lung, maximal inhalation beyond which you cannot inhale more, that's known as your TLC. Your residual volume capacity, basically you blow out and then you reach this point, you cannot blow out anymore, that's your residual volume. This is your tidal volume, your normal breathing pattern, that is your tidal volume. And after you have exhaled during your tidal volume, that volume is your functional residual capacity. So these are important volumes or sub-segment volumes that you need to know in order to make clinical decisions that contribute to clinical decision making. So the other component of this lung inflation is obviously muscles of respiration, and diaphragm is the principal muscle of inspiration. In terms of force, contributes about 70 to 80% of our effort. Inspiration is an active process, whereas in health, and when you're not exercising, expiration is a passive process. Okay. So so in a patient which is dyspneic, among the differential diagnosis you need to consider is whether there is any myopathy or muscle weakness. So respiratory muscle testing is part of pulmonary function testing. So then after that, so from the trachea, the air goes in and then it goes to the alveoli for gas exchange. And that is where the pulmonary circulation comes in. We all know that from the arteriole then to the capillary bed where the gas exchange actually happens and then goes into the pulmonary venous system. So the ability to gas exchange, that means for oxygen to go into the blood circulation and for carbon dioxide to return to the lung to be exhaled. basically depends on two main factors. One is the membrane component, another one is the blood component. So the membrane component, basically the thickness and surface area of the alveoli. That means how much area you have for gas exchange, how thick you are based on Graham's law will let you know about diffusion. Then the interstitium and the endothelium of the alveoli. And this membrane component also includes the red cell membrane. As you know, the capillaries are very small, less than 1 micrometer. So red blood cells which actually flow in the capillaries are very much proximate to this endothelium or the interstitium of the lung parenchyma. So this entire membrane involvement, the thickness, the area, the property of both the interstitium and the red cell membrane will determine the diffusing capacity. And once oxygen or any gas crosses this membrane, the blood factor comes in, wherein the more blood you have, the more potential for gas exchange, and also in a normal hemoglobin, the rate of reaction. So rate of reaction of the gas, how well it can, how fast, or the affinity which it can bind to the hemoglobin will determine the diffusing capacity. So oxygen is not a suitable gas for this because of various technical factors. The gas that we use is carbon monoxide as a surrogate to measure and quantify this process of diffusion. And I'll talk more about DLCO later. It basically implies the surface area and integrity of the structures and components responsible for gas diffusion. So in short, basically how the lung works, there is a conducting airways that bring the gas or the atmospheric air into the lung. And this is only possible if the muscles of the respiratory system work by creating a negative intrapleural pressure. So once it goes from the conducting zone to the gas exchange zone or the transitional respiratory zone, that's where the gas exchange happens based on the principles that I've alluded to earlier. So each one of the aspects that I have highlighted earlier is actually tested in the pulmonary function testing. So I'll subsequently move on to the PFD itself. So the pulmonary function testing is not a precisely defined term. In different centers based on what is available that constitutes their PFD. So what I have listed down here, these are basically what is available locally, not necessarily in every respiratory center, but in most centers, and at least one center in the country will have these tests. So first and foremost is spirometry. Spirometry is probably the most important component of pulmonary function testing, although other tests definitely complement and add value to it. I believe spirometry should be made widely available in countries. There are many clinics health clinics and general medical centers that do not have spirometry services. So spirometry basically requires the subject to exhale fully at maximal speed from full inspiration. Basically, you inspire to TLC and blow out as much and as fast as you can. So the speed and volume will depend on the airway caliber, the elastic recoil property of the lung, and chest wall compliance. So the details of spirometry is actually quite a lot. There are a number of indications and contraindications. I won't be able to go through all those. And also the performance of spirometry is subjected to acceptability and repeatability criteria. I won't go into details of that, but what you need to understand about spirometry, basically it is tests that is highly dependent on the performance of the performer. So if the subject is tachypnic or had a recent cardiac event, we generally don't do for this sort of patients because it is actually a stressful test. And if the subject cannot perform his best exhalation, the test becomes difficult or not acceptable and does not have any value. So spirometry is actually quite old, from Hutchinson's time. It's about 180 years. So this was the traditional spirometry, where just the subject will blow and it will quantify the volume. We have moved far from that. And modern spirometers are actually measure flow and integrate and calculate that translate that into volume. So that is why you don't need such a big bellow anymore. A lot of these spirometers are actually very convenient and very easy to set up, even in clinical kesihatan or general medical units. You have handheld spirometers, those which are USB spirometers. So it's actually not very challenging to set it up. So what from the test performance that I mentioned earlier, basically, which is the maximal exhalation after maximal inhalation, you can actually generate two important curves. The first is a volume time curve, basically volume on the y-axis and time on the x-axis. So so as you blow out, you achieve your fastest rate initially. That's why the slope here is the steepest, until you basically cannot blow out anymore. So this spirograph gives you the volume time curve. How much you blow out in 1 second is your forced expiratory volume in 1 second, and your forced vital capacity is how much you can blow out. So the other curve that can be generated by these machines is the flow volume curve, basically flow on the y-axis and volume on the x-axis. So you start from your total lung capacity, you blow as fast as possible until you cannot blow anymore. So at this point is the residual volume. So this point that you start off is your total lung capacity. So this volume is your forced vital capacity. The expiration is measured positive, and your inspiration, which is measured as negative, comes below. So routinely, we just do expiration in our clinics because the expiration, the flow volume curve of expiration gives us majority of the clinical information that we need in our clinical decision making. You only order for inspiration when you suspect the possibility of upper airway obstruction. Otherwise, you do not need to routinely order inspiration. So how then you interpret these values? The FEV1 over FVC, the ratio which I believe most of you all will be familiar with, and based on this ratio, spirometry basically can give you either obstructive disease or restrictive disease. So the cutoff that we take for obstruction is basically from Gold's COPD recommendation. We take 70% as the cutoff of obstructive airway disease. So for obstructive airway disease, in other words, this ratio will be less than 70%. In restrictive lung disease, the ratio will be normal or high, but reduced FVC value. So, so spirometry serves as a good first test to actually screen for possibility of respiratory disease. Just because the spirometry is normal does not mean there is no respiratory or pulmonary disease, but it's a good first test. And basically, once you have performed the test, if you get an obstructive ratio, your thoughts should be along this line. If you get a restrictive spirometry, then you should be thinking along this line. So in a volume time curve, an obstructive ventilatory defect will look like this. So the broken line is normal. So you can see an obstructive defect basically when flow is slow. Remember earlier the airway I was talking about conductance and resistance. So if there's resistance, the flow will be slow. When the flow is slow, the volume rise will be slow. So you can see it's abnormal. So this sort of appearance is of slow rise is typical of an obstructive ventilatory defect. Also a prolonged time to reach a full expiration. Contrasted to restrictive, basically you see a fast rise as opposed to an obstructive defect, and also you can see it plateau earlier as compared to an obstructive ventilatory defect. So putting it next to each other, I think it's quite clear how obstructive and restrictive defect. This is on visual examination, but you still need to calculate the FEV1 over FVC ratio. So the flow volume curve in obstruction will typically you will see a reduced peak flow, and also the flow curve here will be scooped out. And more severe, in more severe obstruction, you will see further reduction of the peak flow as well as a more scooped out flow curve. As versus to restrictive, you will see a sharp peak, and usually the rise to the peak will be fast, and the flow itself down, you should not see a scooped out pattern. So again, I emphasize this is just how it will visually appear, but you will need to use the FEV1 FVC ratio then to objectively come up with a spirometry conclusion. Okay. So other things that you can actually exploit in performing a spirometry is bronchodilator reversibility. So bronchodilator reversibility, usually you perform it after about 15 minutes of administering about 2 to 4 puffs of salbutamol. So you do a baseline spirometry, then you give bronchodilator, then you give time for the bronchodilator to work, then you repeat your spirometry. What is considered a positive bronchodilator response is an FEV1 increment of 12% and 200 mils. Different literature use slightly different criteria, but this is the often quoted value that is also used in GINA. So, so to demonstrate bronchodilator response, you must fulfill this criteria. The other thing that you can do, which is the opposite of bronchodilator response, actually try to bronchoconstrict the airways, which is bronchial provocation testing. This is done to identify hyperreactive airways. The many agents in Malaysia, this test is only available in Serdang Hospital, and they use methacholine. So I need to mention about upper airway obstruction. This is an important finding, because those clinics or general medical practice that actually have spirometry, you might occasionally encounter this pattern. There is, you don't use the FEV1 FVC to determine upper airway obstruction. There are certain parameters or calculations that you can use, but what is essential is actually the visual recognition of this pattern. So in a patient who's able to perform the test very well, you must be alert to this pattern, because upper airway obstruction is a potential, it is actually a respiratory emergency, or something that actually requires quick or early respiratory workup. So this is one important pattern to recognize and also to act upon. You will need to make an urgent referral to your pulmonary colleague. So we have 3 patterns: the fixed obstruction, in which both the expiratory and inspiratory curves are truncated. In the variable extrathoracic, usually your inspiratory is truncated, whereas your variable intrathoracic, your expiratory is truncated. So basically visual recognition of this pattern is important. Okay, so from spirometry, I move on to lung volumes. So one of the drawbacks of or shortcomings of spirometry is, if you remember, the spirometry procedure is basically from maximal inhalation to and you exhale forcefully until you cannot expire anymore. So what spirometry is unable to interrogate is the residual volume. So you need to know your residual volume to know your functional residual capacity and your total lung capacity. So earlier I mentioned those are actually important clinical parameters in our interpretation and clinical applications. So not all cases will require a full lung function test. A lot clinical decisions can be made just using spirometry, but for more advanced clinical decisions or more advanced procedures sometimes mandate complete knowledge of the lung volumes, and that is where you have to move beyond spirometry. So insofar as lung volumes are concerned, there are two tools or two testings that we can use to measure these lung volumes. One is your body plethysmography, or colloquially, usually we call it the body box. The other one is your multiple breath nitrogen washout. So first, talk about the body box. So the mathematics is rather complicated, but the body box basically is principled upon Boyle's law, which is pressure is inversely related to volume as long as the temperature remains constant. So this is the one that we have in EPO. So this is our body box. So basically the subject sits inside, and it will be sealed. The box will be closed, sealed from atmospheric influence. So the performance of the test basically requires initial tidal breathing, then panting at a frequency of 0.5 to 1 hertz against a closed shutter. So what this will give you is the pressure. We can measure the pressure outside. We can measure the pressure inside. Basically, the panting, the change of volume when your lung is expanding and when your lungs are inflating and exflating, we will be able to calculate based on the formula P1 V1 equals P2 V2 based on the slope of this curve. So based on that, we will be able to calculate the FRC, RV, and TLC. The other test that we can use to calculate lung volumes is multiple breath nitrogen washout. This is basically based on the concentration of nitrogen in the lungs. So this procedure basically involves a closed system, and the subject just tidally breathes, but inhaling 100% oxygen and exhaling out until all the nitrogen has been exhaled out. So basically you're breathing pure oxygen and you try to wash out your nitrogen out. So based on the initial concentrations and the constant mass theorem, we can actually then calculate what was the initial volume that was occupied by the nitrogen in your lung. So then we can derive all the other parameters such as FRC, RV, and TLC. Don't worry too much about the calculations. What you need to know is basically these are the two procedures that can be used to calculate lung volumes beyond what spirometry can offer. The total lung capacity is the gold standard to define pulmonary restriction, although spirometry can give you a restrictive ventilatory defect physiological diagnosis. There are times where it will be, you can get a mixed picture, and also you can get a non-specific spirometry, which mandates lung volume measurement. And based on the current standard, total lung capacity is the gold standard to define a restrictive lung disease. And further lung volume subdivision measurements allows finer clinical diagnosis and prognostication besides actually clarifying the non-specific results seen in spirometry. So that was earlier, so I started off with spirometry, then I went into lung volumes. Lung volumes, basically you can do a body box or multiple breath nitrogen washout. The third component is single breath nitrogen washout. This is not this is a good test, but not a super important test. Even if you don't have it, a lot of clinical decisions can be made. And this test does not actually offer information which we use to make important clinical decisions in modern pulmonology. However, this single breath nitrogen washout, it lends information for you to sort of certify an involvement of airway disorder. So in other words, this is actually a distribution of ventilation testing. So it lets you know how well ventilation is distributed, how well are the time constants of your alveoli unit. It begins with a subject inhaling pure oxygen, just like your multiple breath, but this one only one inhalation. You start from the residual volume, and then you evenly exhale out what you have breathed. So initially so the sensor will measure the nitrogen concentration which is exhaled out. We are interested usually in slope 3, phase 3, which is phase 3 actually represents the alveolar component, or the distal airway component of this one. So a high slope actually represents a highly heterogeneous ventilatory distribution, which is suggestive of an airway etiology. So the next one is actually diffusion capacity, DLCO. So DLCO, basic concept of DLCO is you actually breathe in gas which has certain amount of breathe in a concoction of gas which has various gas. The carbon monoxide, the CO is there. A tracer gas is there, which can be methane or helium with oxygen N2. So the DLCO is basically calculated based on the difference between inhale and sample gas from your exhalation. So when you you actually inhale this gas, you already know the concentration because that is fixed, and then you breath hold for a while. You breath hold for a while to allow the diffusion to happen, then you blow out. And based on the concentration of what you blow out, we can do calculations to measure the diffusion that has taken place, and that will let us know the integrity of the gas exchange. So as I mentioned much earlier during the primer, the correction is actually made for hemoglobin. So we will need your hemoglobin prior to doing this test. So we will make an adjustment to this, because as you know, if you're anemic, your DLCO gas exchange value will be affected. So we would like a standardized value corrected for your hemoglobin for standard interpretation. So diseases that can affect the DLCO are those that basically affect the interstitium, or either in the lung or your pulmonary vessels. And those diseases that can actually give increased DLCO as asthma and pulmonary hemorrhage. Obesity in a significant proportion, yes, but it is still controversial. You don't get increased DLCO in those who are super obese, but mid-range obesity is one of the causes for increased DLCO. So from spirometry, lung volumes, ventilatory distribution, to gas exchange, to respiratory muscle testing. So this test basically tests your respiratory strength and both your inspiratory and expiratory tents. So you tend to do this test when a patient has a restrictive spirometry to rule out the neuromuscular etiology. Usually we do it in patients who we suspect to have some neuromuscular pathology. So the last component of the test is IOS, which is impulse oscillometry. It's a novel technique to measure airway resistance and other parameters, but the other parameters are not very clinically powerful. But it's what the beauty about this test, it's extremely easy to perform. The picture here with a child performing it is actually intended to show that it's an easy to perform test because all you need is tidal breathing. Basically, this is the iOS that we have in Ipoh. Basically, you have a loudspeaker to generate sound waves into your airway. And as you breathe in and out, whatever reflect from your lungs will be measured, and using a Fourier transformation calculation, they will come up with this sort of values. So the principal utilization of iOS is actually to measure resistance, and the beauty of it, using different frequency of the sound waves. So the sound waves that are generated by a loudspeaker, actually the sound waves can be generated at varying frequency, and depending on the frequency, the sound waves can either go to all over your airways or just to your proximal airways. So at 5 Hertz, usually it involves the proximal and distal airways, and at 20 Hertz, you usually get your proximal airways. So R5 minus R20 actually gives you your peripheral airway resistance. So in certain phenotypes of asthma or certain respiratory diseases which only have distal obstruction but not proximal obstruction, you can actually use iOS to demonstrate peripheral airway obstruction or small airway obstruction. So small airway disease is quite popular in asthma. It's a concept quite popular in asthma, and in certain patients, you can actually use iOS to demonstrate the presence of peripheral airway obstruction. Okay, so briefly, some general rules about pulmonary function tests. So what does it offer? So basically, PFT puts patients into physiologic headings or buckets. So it does not on its own diagnose a specific disease. So you don't do, it's quite similar as radiology. You don't just do that and expect a firm diagnosis. So PFT just gives you a physiological heading and able to classify the severity of disease. So you don't do a PFT and get a confirmatory respiratory diagnosis. It's part of the process of making your diagnosis. The second one, the normal values of PFT testing. So what is normal value? Traditionally, we have always said it's 80 to 120% in traditional textbooks. That is what is often quoted. Of course, these values depend on age, gender, race, your habitus, and all those sort of things. But you have to acknowledge that each test its own natural variability in a unique population. So we have sort of moved on from this 80 to 120%. Now we actually use the lower limit of normal value, which is based on the Bell's curve. So the last 2.5% year and 2.5% that calculation. So most of the PFT machines, the new ones bought in Malaysia, for a few respiratory centers in Malaysia, actually now we just use the percentile method for upper limit and lower limit of normal. We don't use the fixed 80 to 120%. And third, this is something that I've not had the luxury in terms of time to talk about, which is technical and performance validity. So each one of the tests that I mentioned, especially spirometry, it is important how the test is actually performed. If the test is not performed correctly, the test is as good as useless, because performance validity is actually very important in the interpretation, and that is where your technician or your medical assistant becomes very crucial. So how they instruct, how they motivate the patient is actually very crucial to how valuable the test becomes. So those are just some brief general rules that you all will probably need to read more about it. Last part of my talk is actually to go into the clinical role. I just noticed I'm running out of time, so I'll talk a bit faster. So as I mentioned earlier, PFTs actually contribute to clinical diagnosis as an adjunct, but on its own, it's not diagnostic. So by placing a patient in physiologic bucket, it contributes to the diagnostic process. An example, this was a patient that was actually referred to our clinic from one of the peripheral clinics, near normal chest X-ray. The patient actually had area hyperresponsiveness, wheezing, night symptoms, basically ticked every box for the diagnosis of asthma. So what the peripheral clinic actually did was actually start the patient on inhalers, but because of no response, they was actually referred to our clinic for severe asthma. So we actually did we did a full lung function by just showing the spirometry to show just the spirometry can actually help in the workup of this patient. The spirometry was actually restrictive. The if you can see the ratio here, is actually restrictive. This curve is typical of restrictive lung disease. So this is not consistent with asthma. So we proceeded with HRCT, suspicious of hypersensitive pneumonitis. They actually sent to Serdang for a lung cryobiopsy, which is reported as hypersensitive pneumonitis. So this just shows how crucial spirometry is in the diagnostic process of the patient. This is clinically you wouldn't blame the clinic, because the patient had virtually classical symptoms of asthma, but asthma can actually hypersensitive pneumonitis can actually mimic asthma, and which is why clinical diagnosis on its own is actually inadequate. If you do not have spirometry services, you're actually in a way handicapped. Another thing that we usually exploit pulmonary function testing is to prognostic preoperatively. These are ERS and ATS guidelines, but if you notice, FEV1 and DLCO is quite central in how we determine suitability or prognostication for thoracic surgery. The other important thing is actually monitoring lung function over time. This probably was less important in the past, but recently there's been a wave of knowledge in ILD, and also a lot of novel new treatments in this disease. So monitoring these patients over time becomes quite crucial, and these are all the parameters used in the landmark clinical trials. So if you're actually treating these patients, you need to have pulmonary function testing in your center. Also, hopefully in the coming years, we will be able to establish a lung transplant in this country, and also those patients post lung transplantation will need continuous monitoring over time. And this graph actually shows a classical long-term complication of lung transplantation, which is bronchiolitis obliterans. We also use lung function to, as you all know, in COPD, GOLD mandates spirometry as part of the diagnostic process. We also use it for to assess certain disease severity. And in the last 10 years or so, a lot of new fancy procedures have made their way into the realm of pulmonology. Bronchial thermoplasty for asthma patients. You need to do a spirometry. You need to do probably a full lung function test to, one, make sure you're not missing other diagnoses, and two, to also ascertain safety for the procedure. For bronchoscopic lung volume reduction, which is basically the insertion of valves to reduce your lung and also improve symptoms, mainly in emphysematous patients. a lot of all clinical trials used full lung function parameters to actually determine suitability for these procedures. So PFTs have become inescapable. So in conclusion, to completely manage the entire spectrum of respiratory diseases, PFT is indispensable. There's multiple components which actually contribute to final conclusion, but not necessarily the final diagnosis. It's an adjunct to making a respiratory diagnosis and also to plan for procedures. So applying the test correctly helps in clinical decision making. So that's my last slide. Just before I sign off, I'll just take this opportunity to promote an event that is to happen between 8 to 10th October 2021. This is an event, APCB, focusing on bronchology and interventional pulmonology, which Dr. Jamalul himself is the chairman of this committee. So you can go to this website for further information on how to register and how to make your payment. With that, I thank you.
Thank you very much, Dr. Kumaresh, for that excellent talk. It's rather refreshing to me, because we learn all this stuff, during our medical student days, and I must admit it was one of the most difficult concepts to grasp, actually, and when we were exposed to all the terms for the first time as a medical student, it was just mind-boggling, actually. And now, so we had learned that all this stuff before. Now it was like a revision to us, and we can improve our understanding further, actually. So we have about 10 minutes or so, for Q&A. I already have a couple of questions in the Q&A box there. Maybe we can answer these questions, Dr. Kumaresh. The first one there, for reversibility testing, some books seem to promote FVC rather than FEV1. So do you think FVC is a good parameter when you interpret reversibility testing rather than FEV1? I mean, you know that 12% and 200 mil there, but do you think FVC is as good as FEV1, or should we just focus on FEV1?
Yes, I think most of the landmark asthma trials, when they use the bronchodilator reversibility, they use the criteria that is mentioned, and that's the criteria which GINA most endorses. However, the earlier European guidelines actually gave a lot of emphasis to FVC. There's been numerous publications that have shown that FVC reversibility itself is a predictor of eventual treatment response. So when you do your bronchodilator reversibility, from my perspective, there are actually two things that matter. One, you want to know the bronchodilator reversibility, whether it's diagnostically useful or not. But the other thing that which is less emphasized, is actually whether you want to know whether it is therapeutically meaningful or not. And there's a lot of publications that actually have shown that using FVC as one of the parameters to assess reversibility actually is therapeutically meaningful. And usually when it comes to FVC reversibility, it is of small airway disease etiology, because what happens when you do a spirometry is actually air trapping, and you actually bronchodilate, you reduce air trapping, and that is best manifested by FVC rather than FEV1. So I hope I came across clear just now. Probably I just repeat myself to be clearer. So you do your spirometry, you get an obstructive ventricular defect. I bronchodilate, then I repeat the spirometry. So FEV1 can increase, but if you get a significant FVC improvement, usually that suggests that there is a small airway obstruction and there's air trapping, And when you administered the bronchodilator, you open the airways, so there is less air trapping. So the amount of air that you can actually blow out increases significantly. So that is why therapeutic. When those other publications that actually explored FVC as a parameter of reversibility, actually they showed there is a strong or equally strong, if not stronger, prediction value of the FVC in the therapeutic sense. But I must say, just because that regardless FEV1 or FVC, if you do not have bronchodilator reversibility, that does not mean that the patient won't clinically respond to bronchodilators. That's important to remember. GINA endorses the FEV1 criteria basically as a diagnostic tool, not as a therapeutic response tool.
All right, thanks for that. And then the second question is, it's good if you can answer live. Is IOS and impulse oscillometry considered as a more superior method in detecting small airway disease, or any other methods besides IOS to diagnose a small airway disease?
Yes, so the thing is, IOS has not been tested against the other traditional parameters of pulmonary function testing in terms of assessment of small airway parameters. So the other parameters that I didn't mention earlier to indicate small airway disease, like residual volume, your RVTLC, your VATLC, those are all traditional parameters of small airway disease. IOS has not been directly in a clinical setting compared head-to-head and not prospectively evaluated whether it's a better predictor for treatment response or hard clinical points. However, based on the basic physics and basic aerodynamics, it appears certainly that IOS is a more sensitive predictor of small airway involvement. I talked about R5 minus R20, but the other parameters like the area of reactance and your resonant frequency, those are very sensitive for your small airway disease, but they are not specific. R5, R20 is pretty specific for peripheral airway obstruction and pretty sensitive. We think that it is more sensitive. A lot of people, but this is a new toys, and when you get new toys, you get people who are highly enthusiastic and publish in a way that it's in a very proactive way. So there's a wave or a surge to believe that it is a superior test. But in terms of clinical value, it has not proven superior to in terms of hard clinical endpoints, it's not proven superior to existing parameters. But the strongest value for IOS is the ease which you can perform it. I think Dr. Jamalul will agree with me. A lot of patients can't do your body box, even your other things. But IOS, even children do it. So it's the easiest. Basically, it's, I think, fair to say if you can't do IOS, you're not going to be able to do the other tests.
Precisely, I totally agree, Dr. Kumaresh. So we have about 3 minutes, about 2 minutes to go. I just wonder, maybe no other questions in the Q&A box there. Maybe one quick question to Dr. Kumaresh. When are you going to start bronchial provocation test in people?
Okay. All right. We finally got our FINO just 1-2 weeks ago. The next step is actually to start BPT. Yeah, I hope by at least before end of this year or early next year. But I think only Sedang is offering this service at the moment.
I think it's good to have one center in the north offering this. So I'm being reminded by Dr. Jivan there that time is almost up there. So I'll just, yeah.
Yeah. So you want to conclude, Dr. Jamalul?
I just say thank you very much to Dr. Kumaresh for the excellent talk. And thanks to the participant, very good attendance actually. Thank you so much for your involvement in this session. Over to you, Dr. Jeevan.
Hi, Dr. Jamalul and Dr. Kumaresh. Thanks a lot for today's session. Dr. Jamalul and Dr. Kumaresh will be closing our session today. Next week will be our last week of our respiratory month. The topic will be COVID-19 pandemic and also TB control. So end of this session, we have a QR code so that you can scan our QR code in a MMA app so that can get one CPD point. So thanks a lot for joining us. Thanks.
Thank you.
Assalamualaikum dan selamat petang kepada doktor-doktor dan juga encik puan sekalian. QR code ni adalah untuk doktor-doktor dan juga physician. Tetapi sekiranya doktor dan juga puan tuan tak dapat scan, jangan risau kerana pihak kami akan masukkan nama puan dan juga IC semua dalam MMA secara manual. Sekian, terima kasih. Saya akan tutup Zoom ni pada pukul 4:05. Terima kasih. Dan untuk e-certificate, siapa yang dah masuk dalam Zoom ni, secara automatik dia dah isi apa yang perlu waktu nak daftar Zoom ni kan, nama, IC dan juga email. Jadi dengan data yang sudah diberi, kami akan hantar e-certificate melalui email yang telah diberi dan juga menggunakan nama dan IC yang dah diberi. Terima kasih kerana menghadiri webinar pada kali ini. Jumpa pada minggu hadapan. Assalamualaikum warahmatullahi wabarakatuh.